surgeon. Sorry about that. So my name is Stephanie Balan, and this is factors influencing surgeon decision-making and bone graft selection during spinal fusion. So spinal fusion connects two or more bones in the spine, typically done to reshape the spine, which is correcting ways with the spine initially being formed, such as having scoliosis. To correct spinal weakness or instability, which occurs when there's too much motion happening between two spinal bones, leading to an unstable spine. As well as repairing a damaged disc, which stabilizes the spine after a damaged disc is removed. So the procedure goes as follows, where parts of the spinal bones are removed to relieve pressure on the nerve roots. And our removed bone is often saved and used as the graft itself, essentially being recycled back into the body. And it is moved from an area where it is no longer needed to the area that the surgeon now wants to use. Within the surgical procedure, it uses transplanted bone, which is used to repair and to rebuild diseased or damaged bones, which helps to stimulate new bone growth in the area, allowing for two or more vertebrae to fuse together. So within the materials for bone grafts, you have autografts, which are considered to be the gold standard, which are typically taken from the patient's own body, typically from the hip or another part of their body. Allografts, which are obtained from a deceased or living donor, as well as BMP, which is bone morphogenic protein, which is a protein that stimulates the growth of new bone, as well as PHS materials, which is a biocompatible high-performance polymer that is lightweight and minimizes stress on the surrounding bone structures. In addition, there are two different types of bone grafts. You have structural and non-structural, where structural is able to provide more immediate mechanical support to promote that bone growth. These are typically more larger, solid pieces of bone, whereas non-structural is primarily to stimulate bone fusion without any significant structural support, by which these are more smaller, more broken down pieces of bone. Just like any other surgery, there are also risks involved, such as infection, bleeding, blood clots, and even the return of symptoms. So Joe et al. 2018 determined how when there's insufficient residual bone, implant placement does become difficult, which would be when autogenous bone or autografts would be the ideal type of graft material. But as mentioned before, since autografts are taken from the patient's own body, there can be disadvantages for the donor site problems and limitations of the harvesting amounts. Reisner et al. 2020 discussed how the overall improved safety for spinal fusion procedures over time has led for indications for spinal fusion to broaden over time as well. From 6.2 to 14.2 of procedures per 100,000 population from 1993 to 2012. This can be seen in efficient bone grafts to have a decreased utilization due to higher cost and more restricted approval for the usage of new types of bone graft material. Pucci et al. 2019 also discussed how there were ethical, religious, and or medical concerns tied to bone graft origin, specifically looking at patient preferences. So autologous bone had the fear of pain and discomfort. Xenografts, in particular, they come from a species different from that of the patient. So these had the fear of disease transmission as well as the use of animals for human benefit, which can have religious complications, as well as allografts having ethical, moral motivations, as well as the fear of disease transmission. So this concluded how religious affiliation does influence the patient's preferences of bone graft selection. And so Unit 2017 came to the conclusion that most surgeons were not really satisfied with the available literature comparing the effectiveness of grafts. And overall, throughout the literature review, there's been a lack of examination of which specific factors influence surgeon decision-making, as well as whether non-efficacy-related factors such as cost, education, and familiarity influence graft selection. So this can be due to numerous reasons, such as osteobiological material evolving way too quickly with rising technology, a lack of education in biomaterial application, as well as pricing complications. So my hypothesis is that bone graft selection will be more strongly influenced by preferred graft-related factors, such as pricing, familiarity, and education, rather than actual efficacy-related consideration. So with that, I decided to conduct an online global survey, that examined surgeon preferences in bone graft selection, patterns of graft usage in spinal fusion, as well as the variability in graft choice among surgeons. And so the survey questions themselves had literature references towards Unidol 2017, Willie et al. 2011, and Hurdle et al. 2013, where the demographics primarily targeted the spinal surgeon's gender, age, as well as location and years of experience. So for analyzing results, in particular, if the p-value is less than or equal to 0.05, there is a significance value within that. And primarily for my results, I decided to look at strict statistics as well as a repeated measures ANOVA test, primarily using the program Jamovi. And so with the repeated measures ANOVA test, it primarily examined which factor most strongly influences graft choice among the categories of awareness, pricing, and education. And so it was determined that there is a statistically significant difference between at least one of the three influences, as the p-value is equal to 0.004, being less than 0.05. Determining that surgeons do give higher importance ratings to some influences rather than others during graft selection. So my total survey had 16 participants in total, which could be a limitation, as typically 100 participants would be related to more accurate results. However, a majority of my participants did come from North America and Europe, and I only had one coming from Asia. And so it was determined that North America is more likely to have surgeons with 20 plus years of experience in comparison to Europe and Asia. And Europe is also more likely to perform more spinal fusions per year in comparison to North America and Asia as well. And so, as determined, since the NOVA is statistically significant, it indicated that surgeons do not rate all the influences on bone graft selection equally, as if we're looking at awareness, it received the lowest average rating of 2.87, pricing received an average rating of 3.73, and education received the highest average rating of 3.93. So this determined that non-efficacy-related factors do play a more dominant role in graft selection decisions. And so looking at surgeon graft selection based on the years of experience, you can see how surgeons consistently rely on audiografts and familiar materials across numerous years of practice. As you can see, the pattern does persist across numerous years. And there's also very little diversification towards more newer and more synthetic grafts. So this came to the conclusion that regardless of the years of experience, surgeons do consistently rely on traditional graft materials, suggesting long-established preference patterns. So in addition, looking at the change in graft technique within the last year, based on years of practice and their region, all respondents did report no change in graft technique over the past year, specifically from North America and Europe, as Asia exempted themselves from this question. In addition, this has shown how more experienced surgeons are also less likely to change their grafting technique. And overall, despite increasing evidence for alternative grafting options, most surgeons still reported no recent change in their graft technique, particularly for those with greater years of practice. So overall, surgeons did emphasize graft selection being commonly influenced by cost, availability, and even insurance coverage. And as efficacy is considered, it does not solely control the graft selection process, and non-efficacy-related factors also strongly influence graft choice, and highly effective grafts may be under-influenced despite known clinical benefits due to this. So, Unidol 2017 discussed how there was great variability in graft material selection by spine surgeons worldwide, as there was a minor change of selection of graft from the simple to the challenging cases. And so, the gold standard selection for autograft island pressed tricortical bone was at 60%, and PKH material at 22%. So many surgeons do feel that their graft of choice is not the gold standard. However, they still use cage materials, and cage material is not really a cost consideration, as there is no implant cost associated with using cages. So this can be primarily due to convenience or even avoidance of grafting for harvest donor site morbidity. And so with that, Deswanda et al. 2025 discussed how students working at university-affiliated hospitals were also more likely to adapt to newer techniques. In addition, surgeons with higher numbers of operations were also more likely to adapt to newer medical innovations and techniques earlier into their careers, making them more open to newer innovations into their clinical practice. So with that, it also looked at changing clinical practice and the importance ratings among different options, where the least important factor was personal familiarity at 42.4% and advice from mentors at 41.3%, whereas the most important factor was solid clinical evidence at 67.9%. So this determined that simple familiarity alone is insufficient enough to drive adaptation. And so, in conclusion, due to a lack of examination of bone graft selection, my hypothesis is that bone graft selection is more strongly influenced by preferred graft-related factors, such as pricing and community education, rather than actual efficacy-related considerations. So I started to conduct a global survey that examined the surgeon preferences in bone graft selection, patterns of graft usage in the spinal region, as well as variability in graft choice among surgeons. So my findings concluded that surgeons do not rate all of the influences of all influences equally, as bone graft choices are commonly influenced by education, familiarity, pricing and cost considerations, as well as non-efficacy related factors. This is important because decision-making is not solely based on efficacy alone or the efficiency of the graft itself, but it also helps to explain why there is a variability in bone graft usage among surgeons. So for future research, I plan to examine the usage of bone grafts for different fitness levels, rehabilitation time, types of exercise, and the manual labor and the type of job of the patient themselves. If you're an athlete or even a construction worker, you can probably have more prominent back complications in comparison to the normal individual. In addition, I also want to look at the process of how spinal surgeons learn new surgical techniques, as well as the frequency of attending these meetings or conferences discussing these newer innovations, as well as the minimum success rate and survival rate required for surgeons to use a specific type of bone graft. These are my acknowledgments, references, any questions?
Hi, my name is Rebecca Smith, and I'm conducting research involving assessing seasonal spatial overlap between whale sharks and commercial shipping in the Gulf of Mexico under the guidance of my mentor, Joseph Gandia and Eric Hoffmeyer. If there are any questions for Stephanie, they can ask now. Okay, it's my pleasure to introduce Elizabeth.